Today, we are going to understand urticaria, commonly known as hives, in a way that goes beyond simple definitions and helps you think clinically, exactly how you would approach a patient in real life or in an exam. Urticaria is one of the most frequently encountered dermatological conditions, yet it is often misunderstood because of its wide variety of triggers, presentations, and underlying mechanisms. So let's build this concept step by step, starting from the microscopic level and moving all the way to bedside management. At the core of urticaria lies a single critical event: mast cell degranulation. Mast cells are immune cells present in the skin and mucosa, and when activated, they release a cascade of mediators, the most important being histamine, along with others like bradykinin and leukotrienes. This release leads to two major vascular effects: vasodilation and increased vascular permeability. Vasodilation causes redness, while increased permeability allows fluid to leak into the superficial dermis, forming the characteristic wheals, which are raised, edematous lesions. This is why urticaria is classically described as wheals and flare, the wheal being the raised swelling and the flare being the surrounding redness. Now, what triggers mast cells to degranulate? In many cases, this process is IgE-mediated, especially in allergic reactions where allergens like food, drugs, or insect stings cross-link IgE antibodies on mast cells. However, urticaria is not always allergic. It can also be non-IgE-mediated, where direct triggers like physical stimuli, such as cold, pressure, or heat, or certain drugs can activate mast cells without involving antibodies. This distinction is important because it influences how we approach diagnosis and management. Moving on to the clinical presentation, urticaria is typically characterized by itchy, raised wheals that can appear anywhere on the body. These lesions are often transient, meaning each individual wheal usually lasts less than 24 hours, even though new ones may keep appearing. This fleeting nature is a key diagnostic clue. The itching can be intense and is often the most distressing symptom for patients. In some cases, urticaria is accompanied by angioedema, which involves deeper layers of the skin and presents as swelling of the lips, eyelids, or face. Unlike wheals, angioedema may be painful rather than itchy and can last longer. Urticaria can be broadly classified into different types based on duration and triggers. Acute urticaria lasts for less than 6 weeks and often has an identifiable trigger, such as a food allergy or infection. In contrast, chronic urticaria, which persists for more than 6 weeks, is often idiopathic or autoimmune, meaning no clear external trigger is found. Another important category is inducible urticaria, where symptoms are triggered by specific physical stimuli, such as cold exposure, heat, pressure, or even exercise. This includes types like cold urticaria, cholinergic urticaria, and pressure urticaria. Now let's talk about diagnosis, which is largely clinical. In most cases, especially acute urticaria, a detailed history and physical examination are sufficient. We focus on identifying triggers, recent foods, medications, infections, or environmental exposures. Extensive investigations are usually not required in simple cases. However, in chronic urticaria, we may perform basic tests such as a complete blood count, inflammatory markers like ESR or CRP, and IgE levels, to look for underlying causes or associated conditions. In some cases, we may also check for autoimmune markers, especially if we suspect chronic spontaneous urticaria. For inducible urticaria, we can perform provocation tests, such as applying an ice cube to the skin for cold urticaria or using pressure devices to reproduce symptoms. Skin prick testing may be useful in suspected allergic cases, but it is not routinely required. Importantly, skin biopsy is rarely needed unless there is suspicion of urticarial vasculitis, which presents differently with longer-lasting lesions and possible systemic involvement. Now comes the most important part: treatment strategies, where we move from understanding the disease to actively managing it. The cornerstone of treatment is antihistamines, specifically second-generation Hone antihistamines, such as cetirizine, loratadine, or fexofenadine. These are preferred because they are effective and non-sedating, making them suitable for long-term use. If symptoms are not controlled with standard doses, we can increase the dose up to 4 times the usual level, which is a key step many clinicians overlook. For patients who do not respond adequately, we move to third-line therapies, such as omalizumab, an anti-IgE monoclonal antibody that has shown excellent results in chronic urticaria. In refractory cases, immunosuppressants like cyclosporin may be considered. For acute severe episodes, short courses of oral corticosteroids can provide rapid relief, but they are not recommended for long-term use due to side effects. In addition to medications, trigger avoidance is a critical aspect of management. If a specific trigger is identified, such as a food or drug, it should be avoided. However, in many cases, especially chronic urticaria, triggers are not clearly identifiable, which can be frustrating for both patients and clinicians. This brings us to lifestyle and supportive measures, which play a significant role in symptom control. Simple interventions like cool baths, cold compresses, and wearing loose, breathable clothing can help reduce itching and irritation. Patients should avoid known aggravating factors such as heat, stress, alcohol, and certain foods. Keeping a symptom diary can be very helpful in identifying patterns or triggers over time. Emotional support is also important, as chronic urticaria can significantly impact quality of life due to persistent itching and cosmetic concerns. Finally, let's discuss some high-yield reminders and complications, which are extremely important in clinical practice. The most critical point is to differentiate urticaria from anaphylaxis. While urticaria involves skin manifestations, anaphylaxis is a systemic, life-threatening reaction that includes airway compromise, hypotension, and multi-organ involvement. In such cases, the treatment is not antihistamines, it is immediate intramuscular epinephrine. This distinction can be life-saving. Another important point is that urticaria and angioedema often occur together, and angioedema involving the upper airway can lead to airway obstruction, which is a medical emergency. Chronic urticaria is often autoimmune in nature, and patients may require long-term management and reassurance. There is also a rare but important condition called urticarial vasculitis, where lesions last longer than 24 hours, may be painful, and can leave behind pigmentation. This condition may be associated with systemic involvement and requires a different approach. To summarize, urticaria is a condition driven by mast cell activation and histamine release, leading to transient wheals and itching. It can be acute or chronic, allergic or non-allergic, and requires a structured approach to diagnosis and management. The key to effective treatment lies in understanding the underlying mechanism, using antihistamines appropriately, avoiding triggers, and recognizing red flags like anaphylaxis. So the next time you see a patient with hives, don't just treat the rash. Think about the mechanism, identify the type, rule out emergencies, and manage holistically. That is the clinical approach to urticaria.